The budget is bitter, but the Coke is sweet. This is America Dissected. I'm your host, Dr. Abdul and
And I'm your co-host, Dr. Caitlin Jetelina.
and we're recording this on Tuesday, July 22nd at 2 p.m. Eastern Time. Caitlin, let's do a quick vibe check. How you doing?
I'm doing okay. Do I dare say it that it feels that it's a slow week in health news? Should we be knocking on that wood behind you, Abdul? I mean, yeah, I'm afraid to say that. But it seems that like we can catch our breath these past couple days.
I've just switched I'm at an Airbnb, and incidentally in your neck of the woods, and we have all of our dessert cereals. I feel like I'm going to get gone after by the Maha crowd here, so I had to
It's
switch
okay.
my background. Um, yeah, having a quieter week in health news is like definitely a win because it's always been bad. But like you got to imagine the contrapositive where you have a good week and a lot of news to cover because it's all good news. Like that's what we want to play for. And I think sometimes we
True.
forget that. They're like there can be good health news, and there should be good health news. Like we can have nice things if we're willing to play for them.
Yes. And you're in LA.
I am in LA. I am in LA. We had a family wedding, which was lovely. Like truly a lovely, lovely wedding with some of the best wedding food I've ever had. Like I've usually when it comes to wedding food, I'm like, but they had like this lunch, and I didn't know this was a thing, but they do Brazilian barbecue that is like mobile. So
Oh,
they
that's
bring the
cool.
Brazilian barbecue to the house. And so like I ate so much ribeye. It was nuts.
Sounds
So
amazing.
it was awesome. It was very, very
And
good.
weddings are so much joy.
It
Like
really
it is just a great, happy time. And so I'm glad you're here in the great state of California.
I know, but it's no Michigan. I have to it's no Michigan. I love me some Michigan. Michigan's just I love California every time I come here. Like I really like there are amazing things about every part of the country. California has a unique sort of blend of just like culture and weather and like chill vibes. But then part of me is like, I just miss like Michigan has this like earnest grit that is unbeatable. And every time I leave Michigan, I'm always like, I'm grateful to be from here. So
It's your home.
it is. On news, uh, we pray for a world in which someday we can talk about good news. But let's actually start at something that's like not the worst. So last Friday, Congress reinstated $400 million in global AIDS relief funding, also known as PEPFAR, which is originated as the President's Emergency Plan for AIDS Relief. This funding was not included in Trump's big ugly bill, but this was a clawback from Congress in a process called rescission. I have to caveat that this was a win in the context of a lot of losses, but just how big of a win was this?
I think it was a pretty big win. And I'll walk you through a little, but to back up a little, right? PEPFAR, if we remember, is this government program that was launched in 2003 under President Bush, actually, to address the global HIV AIDS crisis. And I think that we have to go back and remember why we did it at the time, right? It was designed as an emergency response, but Bush framed PEPFAR as a reflection of American compassion. In fact, he said that, quote, to whom much is given, much is required. And that PEPFAR funding has made huge strides, right? PEPFAR supports roughly 20 million people on treatment, prevented hundreds of thousands of deaths annually. But what it's PEPFAR has found itself over these past couple months is embedded in this broader foreign aid freeze and dismantlement in the United States. If we remember, like a couple months ago, Trump executed this order to include a 90-day freeze in most of U.S. foreign assistance. This included PEPFAR, but was later waived for HIV treatment as humanitarian aid. But of course, that waiver was delayed and it was chaotic. But you're right. Last week, PEPFAR was again found itself embedded into a $9 million rescission cut or vote, which is basically an emergency vote of already appropriated funds. And there was this massive bipartisan effort to spare the 400 million for PEPFAR, which is fantastic news. I think it's great. Like, let's get this bipartisan win where we can get it. I think that there's a couple of things though here is that it's clear that one, this golden era of PEPFAR is ending, right? Even though we've had this budget is not going to be cut by 400 million, the capacity is still diminished. And what we saw in Project 2025 is that the Republicans in the Trump administration really want to change this from an emergency fund to a more development focused program, which means downplaying the emergency elements. It means probably consolidating partners. It probably means sunsetting lower impact programs. I hope it also means upscaling targeted interventions that work, like PrEP. So I don't know. I mean, this is good news. I don't think it's the end of the story of PEPFAR. I think there's going to be a lot uh, of movement in this space still yet to come. But I'm taking it as a win.
I think we should take it as a win. And I just want to be clear about something. The less HIV there is in the world, the safer Americans are. It should be enough for us to say, given the largesse of our country, we want to be a part of fighting HIV globally. But fighting HIV globally is also about fighting HIV locally. And I also want to offer some caveats. While this is an important win, right, the sunsetting of research investment in things like an HIV vaccine, like that's still unforgivable. And that should have been the direction that we continued to go, regardless of who was president. But I'll celebrate the wins where I can get them.
I agree. And like you said, I mean, I think that we're going to be seeing even more budget cuts. It's really confusing. I thought it's very confusing to keep track of everything that's happening. We've had this big, beautiful bill that was basically reconciliation, which means fast track changes to mandatory spending. Last week, we had this rescission, which basically cancels previously enacted authority. And that's where, these PBS news cuts and Sesame Street memes all came through. But it's also not over. There's a third process still coming down the pipeline. Is that right, Abdul?
That's right. And that's the appropriations process. Now, I just want, to sort of government 101 here. The Congress, right, should Congress continue to respect itself, is supposed to be responsible for appropriating, deciding what money gets spent in government. Now, that gets spent by the executive branch, the branch led by the president. But the way this works is that the administration, the president, will propose a budget, and then that budget has to be signed into law by Congress. That's the appropriation process. That's how all of the agencies, HHS, Department of Justice, you name them, that's how they get funded. Now, the proposed 2026 budget calls for a 25% cut to HHS, that's $32 billion, and a 40% cut to the NIH, which sits under HHS, that would be an $18 billion cut. So if you're doing the math, a lot of the cut to HHS generally comes through cuts to the NIH. Now, don't forget, the National Institutes of Health is a collection of all of these research institutes that both do intramural, meaning based at the NIH research, and then fund extramural research that goes out to governments and other kinds of organizations to engage in key early stage and late stage biomedical research. The NIH is the single biggest funder of research in the world. I want you guys to understand that, in the world. And it's absolutely critical because almost every single new medication that gets discovered had some basis in NIH research. It's also the lifeblood of some of our most important organizations that do research, which are universities. And RFK Jr. defends this budget, claiming that they can do quote unquote more with less. And Congress is going to be taking up this budget in September. So there's opportunities I think we have to continue to push to protect agencies like NIH and CDC and all that fall under the Health and Human Services umbrella. But I want folks to be able to differentiate that between both reconciliation and rescission. Katelyn, as you think through where this heads, what are some of the key issues that you'll be watching when it comes to that HHS budget in particular in September.
Yeah, I mean, I'm like you just mentioned, Abdul. I'm very focused on NIH. It will be the biggest cut in RFK's discretionary funds. And let's not forget that this is not the first time NIH is getting cut. In these first 6 months, more than 5,500 research projects have already been halted. This means thousands of research questions are not being answered. Thousands of communities are not being served. Thousands of researchers are stuck in limbo. There's a huge cohort of training that's been lost for this next generation. And so another fourth of the budget being cut is I don't know, is going to come down to the bones of research discovery in the United States, something that we've never had that big of a cut in. And yeah, you can say all of this research is at the ivory towers and the elites are complaining, et cetera. But like, think about what these research projects actually do. I mean, I was funded as in NIH and the federal government when I was a professor, and I was working on mental health among police officers, for example. And so it's not just drug discovery and making big, huge, risky bets on maybe something we will or will not see in 10 years. I mean, it's direct community engagement right now. It also has huge economical indications and implications. NIH is one of the biggest economic drivers because of jobs. For example, in Alabama, the University of Alabama is the biggest employer of the state. And so this is going to have big trickle down impacts. I think, though, that what you said is right, is that this hasn't been set in stone yet. There are definitely conversations happening right now. And there's actually a lot of bipartisan support behind research. I mean, we've heard it from the Help Committee. We've seen it in the polls. And I think because this engine is invisible, it's hard to see. It's hard to know how it's working for the American people. And that means that us researchers have to do a whole lot better at storytelling and engaging and advocating for this. But
Yeah.
other than NIH, I mean, CDC is going to get cut in this budget. I mean, everything in HHS, basically. The new AHA department will be getting their money. It'll be very interesting to see what they do with this couple $100 million that they should be getting. So I don't know. I'm not looking forward to it. Public health and health in the United States has already been decimated this year. It's going to get worse.
Yeah, and it's interesting, right? When you think about like science investment, I want you to imagine, if you were to use the same logic around venture capital, right? Venture capitalists will make 10 investments and they rely on one of those investments to more than pay for all of the other 10. Now, most folks look at venture capital and say, oh, that's a remarkable engine of growth and productivity. And when it comes to government, we are unwilling to provide the same kind of logical framing, or at least be okay with that same kind of logical framing, because some scientific research projects don't pan out. Some of them, lend you or walk you down pathways or rabbit holes that don't actually have anything at the end. But some of them, right, some of them yield outcomes that are way beyond, right, way beyond anything else you would have invested in terms of both the value derived, but also the public good that gets created out of them. And we've relied on government to be willing to do that basic investment research to help us to unlock some of those discoveries that are out there that might be a little bit too risky. Now, when you call that wasteful or fraudulent or abusive, right, you are coming for the basic engine of biomedical discovery in this country. And it has been very much to the benefit of the public to be able to have this. And so I want us to be willing to actually take on and break down the central logic that they're using. That if every research project doesn't yield fruit, that somehow the research enterprise on its own terms is wasteful, just doesn't make sense, doesn't pan out based on the evidence.
And that's what government's for. It's to invest in services that may not have an ROI. Now, NIH actually does have a positive ROI. For every $1 invested, $2 comes back in local economies. But it's okay if it's not, if it means better livelihoods and better health trajectories down the road. So we'll see what happens. I'm curious about your thoughts, Abdul. Do you think that this budget's going to get through Congress at the end of September? I mean, I'm not sure.
The fact that rescission made it through suggests to me that it will.
So
The
easily.
question is, if you can convince Congress to backpedal on the decisions Congress already made, then it's a lot easier to convince Congress to do a thing moving forward, right? Because by definition,
Yeah.
rescission is be like, we made a mistake, let's walk this back, versus, hey, here's what the president's budget suggests we should do. So I don't have high hopes for Congress blocking things. That being said, as the public learns more and more about what the big ugly bill has done, I think you're going to start seeing more and more public pressure against sitting members of Congress, which may, in fact, start to put some, we'll just say, stiffen their spines. And if that happens, you may see more Congress people willing to stand up to some of these absurd cuts, particularly in hard hit Republican communities, places like you mentioned, Alabama. But I'm not holding my breath, right? Because unfortunately, Republicans have decided that they're more worried about Donald Trump supporting a primary against them than they are worried about having to win in a general election, given how polarized and how geographically polarized we are as a country. So I don't have high hopes, but I do think that being able to call out these very specific programs that we need to save can be really helpful in terms of helping them to carve that out without having to take on big fights against the administration.
One thing I heard from a staffer, which I thought was really interesting, which may be useful to listeners, is they informed me that it's very important to get people calling around this appropriations bill, and a push from constituents can actually significantly impact a senator's decision. Interestingly, though, Republicans tend to push until the end, and Democrats actually tend to peter out. So if you're out there making calls, just keep just keep going, and even start initiating it, especially if this NIH and CDC HHS budget's so important.
Let's pivot to something a bit lighter. So Donald Trump claims he convinced the Coca Cola company to sweeten Coke with cane sugar instead of high fructose corn syrup. Katelyn, what's the word?
I know. I thought it was fake news at first, Abdul. I mean, I don't know. I mean, first of all, Coca Cola hasn't confirmed this yet. This is basically in a number of tweets and HHS announcements. But if it happens, and even if it hasn't been announced by Coca Cola, Maha is already rejoicing, right? They hate high fructose corn syrup. I think that though, like if we get out of the weeds here, this switch is not going to make a difference, guys. Soda is soda. Cane sugar comes from sugar cane and has equal amounts of glucose and fructose, which is a little different than high fructose, but it's still processed. It is still has high sugar. It still increases the risk of obesity and type 2 diabetes. And I'm just getting really sick and tired. And it's only been, what, 6 months of these headlines, and I don't know, the amount of time and money and energy that is going into these very small, if anything, I wouldn't call them wins, and not put towards like actually effective actions that are happening here. It's wild to watch unfold.
You know what? I'm gonna take a slightly different viewpoint on this to say it's a win. It's just not a big win, right? It's like in baseball they play what 100 and some games. It's like you won one game, fantastic. But this is not winning the World Series. And the reason I would worry more about high fructose corn syrup than cane sugar is just simply because it's like hyper palatable, and so there is a
Mm.
certain secondary drive to acquiring it that we think operates now. In the end, you're right. Like the amount of glucose in a can of Coke or a bottle of Coke is going to be the same. And so this doesn't magically make drinking Coke better for you. And like this is where I think your point is the most important, which is to say, yes, high fructose corn syrup, bad, worse than normal sugar. I think it's good that we remove it from more products. I worry though that when you change what the nature of a victory is and you say this is the ultimate win, what you're saying now to the public is we replaced the high fructose corn syrup with cane sugar, that now Coke is healthy for you. It's not. It's just not healthy for you. So this is the worry that I have, which is like all of a sudden people are like, well, it doesn't have high fructose corn syrup, so it's good. You're like, well, no, you're just drinking sugar. It's just sugar of a slightly different molecule that may be slightly less hyperpalatable than what you're drinking, and this doesn't magically make sugar sweetened Coke better for you.
Yeah. I mean, one thing that I've seen on social media around this is Maha celebrating that our Coke products are going to be looking more and more like Europe's without understanding that it's not because it's healthier that we use it in the United States. It's cheaper by design from these US foreign policies of subsidizing massive corn production
Yes.
and imposing tariffs and quotas on imported cane sugar, right? This has made high fructose corn syrup far more affordable option in the United States compared to other countries where these subsidies and protections are far less for high fructose corn syrup. And so this isn't necessarily the use of it over the years, I don't think has necessarily been a nutritional one, but it's just the economic and policy choice due to the corn production.
That and if you want it to look like Europe, you don't see in Europe, you don't see that 20-ounce bottle. So part of me just says, okay, like the reason that in
Unfortunately.
Europe there's not as much consumption is because A, to your point, we make it artificially cheap here, and then B, because it's artificially cheap, we sell it in amounts that shouldn't be drunk. So if you want to have like one of those like mini cans or one of the original bottles of Coke, okay, like, and if we sold it in that denomination, people might not drink as much of it. The problem is that the most common form that's out there is either the can or the 20-ounce bottle, right? And that there is part of the challenge, is that we have portion size challenges here. So whether it's that portion of cane sugar sweetened Coke or high fructose corn syrup sweetened Coke, is still a hell of a lot of sugar that you probably shouldn't be drinking anyway, right? And I really appreciate your point about the economics of this, because that's what tends to drive a lot of this overconsumption, is like artificially cheap to get a 20-ounce bottle of huge amounts of sugar, like 240 calories of just straight up sugar. Right? Almost every calorie in a bottle of Coke is coming from the purest form of sugar. So sure, high fructose corn syrup or cane sugar, maybe we just shouldn't be drinking 20 ounces of either of them.
Yeah, and guess what else Europe has is a healthcare system. So, and we are defunding
That
healthcare
part.
and research and SNAP benefits. So there are even, I mean, it's just you have to take the whole picture into account. And I
Which Maha is like decidedly not very good at. It's like
no, on
it's like they look
purpose.
at one piece of the puzzle and they're like, all right, we should just fix this piece. And you're like, no, no, no. You have to fit it into the rest of the puzzle and see whether or not you like the picture it creates.
That's why I think it's all so what is the word? Like so performative.
Yes.
And it's ah it's hard to watch, but we'll see. We'll see if they make bigger changes.
America Dissected is brought to you by Life Kit. From fitness routines to mental resilience, navigating personal goals to tackling burnout, we all need a little help being human. That's what the Life Kit podcast from NPR is here to do. If you're looking to move with more intention or just need help, thoughtful guidance on living better, Life Kit delivers strategies to help you make meaningful, sustainable change. Life doesn't come with a manual, but every day you're making choices, some big, some small, that shape the direction of your life. Life Kit offers real stories, relevant insights, and clear takeaways to help you meet those decision-making moments with confidence and clarity. I really love the recent episode they did on how to avoid mosquito bites because, well, we all know that mosquitoes suck, literally, but it's hard to know how to avoid them, especially if you're someone they seem to really like me. I listen to Life Kit because I get to hear thoughtful conversations that unpack the emotional and practical side of personal wellness, actionable guidance I can actually use, no fluff or judgment, and trusted voices and expert advice to help take me to the next step, however big or small. Get help tackling common issues like relationships, finances, parenting, and your career. Then walk away with a game plan you can implement right away. Life Kit isn't just another podcast about self improvement, it's about understanding how to live a little better starting now. Listen now to the Life Kit podcast from NPR. One of the threads that we don't ever really connect is the way in which online culture has like transmogrified itself into real life, right? Like so much of like the
Yeah.
Maha influencer crowd is they transact their influence in the form of a reel on Instagram or a TikTok where they're literally performing health. And the hard part about it is that health is a status, it's not a performance. And there are some aspects of it that you do. It's like choices that are made in the kitchen. There are choices that are made about movement and exercise. And don't get me wrong, eating healthy and exercising are always really good to do. The hard part about it though is that those are not the parts that government like is built to do. And if you were serious about empowering government to do it, you have to go way deeper than high fructose corn syrup, right? You have to go into like the subsidies that we tend to pass, the way that we think about agriculture generally in this country. I had the opportunity to tour a berry farm, right? And it's a family-owned berry farm that's been in this family for generations. It's fascinating to me the degree to which like these people are making genuinely healthy foods, and they don't get the subsidies that corn and soy farmers get. They're a family outfit. The farmer lives on the farm rather than it being a publicly traded corporation based out of Delaware. And we talk about, right, like farmers, the idea we have about farmers in our minds are these folks, but the way that our government thinks about farming is these other folks. And we end up getting it entirely wrong. And if you're willing to actually stand up and say, hey, maybe we should be subsidizing blueberries from Michigan instead of subsidizing corn and soy, folks are like, well, you just seem to hate the agricultural way of life. It's like, no, like actually you're missing the whole point. And I would love to see the Maha folks get involved on that front. Like, I think we'd be really smart. And also, by the way, guess what else is an agriculture issue? Immigration, right? Because the people who are most likely to actually do the actual farming on the farm, like the day-to-day labor, they don't tend to be folks who are born and raised here, right? Those folks don't tend to want to do the work, even if it makes 18 bucks an hour and comes with transportation and housing. You know what else is? Climate change, right? Like I talked to a farmer, like if you grow cherries, which we grow a lot of in Michigan, it takes 7 years for you to put a tree in the ground for that tree to bear a single cherry. And if the climate has changed enough in the 7 years, you spent all that money up front to grow your trees, and then at some point the yield on that investment goes down because of climate. And so like if we're serious about fixing our food space in this country, which I really desperately hope we get serious about, then we got to put all of these things into one picture. But to your point, right, like we're too busy focusing on this one puzzle piece. um and it makes it easy, and that's like a function of like just social media logic about the performance of health versus the actual foundations and structures of health in this country.
Yeah, social media is all just politics, right? Like RFK needs wins. He's pissing off a lot of people in the vaccine space. And so it's so politically driven too that it's it, it doesn't seem genuine, I'll be honest. It just
No.
doesn't seem genuine. But you're right. We'll see if there's any big moves that are made in the future. We still have 3.5 years of this, Abdul.
All right, I'm done. I'm out. um, uh, all right, two other public health stories that caught our eyes this month. The first is that after a very, very long time, heart attacks are no longer the leading cause of death in the United States. In fact, heart attack deaths have fallen by almost 90% in the US since 1970. Things like interventional radiology and stenting have fundamentally changed the outcome of heart attacks and made them so much more survivable. And now people who have had heart attacks tend to live quite a bit longer, but they have to deal with the long-term consequence. And so that's what's replaced heart attacks. So acute, meaning immediate heart disease, has been the long-term outcomes of previous heart attacks. So heart failure over time. So just to explain the physiology here, when you get a heart attack, what's happening is that there is some upstream blockage of blood to some part of the heart. When that happens, that heart muscle dies. And if that heart muscle dies, what happens is that it can no longer participate in the work of the heart, which is beating to move blood all over your body. And when that part of it dies, it means that the rest of the heart has to work a lot harder. And over time, what happens is that heart muscle gets exhausted, and you end up getting what's heart failure. You get backing up of blood into your lungs and a number of other things. And that's now replaced acute myocardial infarction or quick onset heart attacks as the leading cause of death. Um, Kayla, what do you make of this news, and how do you think we should be thinking about it from a public health and healthcare standpoint?
I think it's pretty big news. I mean, heart attacks have been like like you said, leading cause of death. And for it to decrease, I think it's what been 90% or something crazy over the past couple decades is huge, uh, huge advancement. It really is. And it is the leading cause of death in the United States around the heart health, right? And I think it goes back to our earlier conversation about NIH, right? Our investments in science and trying to understand what these pathways are in cholesterol lowering drugs and biomedical devices, as well as more of the soft indirect ways of just public awareness campaigns, right? How to spot a heart attack, how to discuss the history of heart health with your physician and your family history. So I think it's incredible. I think we still have a ton to go forward, though, with heart health in the United States. We also saw a review in JAMA. So there's not only changing trends in heart health, but in GI, particularly cancers, are up sharply in young people. In fact, one of my friends actually just got diagnosed last week with stage 4 colon
Mm.
cancer. And so it's not just these anecdotal things. We're starting to see these trends in the data that more young people are getting colorectal cancer, and particularly a sharp increase in pancreatic and stomach cancers as well over the past 5 years. I think the biggest question is why? Why are we all of a sudden seeing a rise in cancers, particularly these gastrointestinal cancer trends among younger people? And my understanding is that we don't really know why. There's been a couple hypotheses, but usually when we see this massive trend, as you know, Abdul, it's called a cohort effect in epidemiology, which means that there's probably some environmental reason that's causing this phenomenon. Our genetics haven't changed, so it's not that, but it's likely our environment. I think a lot of questions are rising around ultra processed foods, around lifestyle factors like lack of exercise or alcohol consumption. I saw a really interesting study about a month ago around our gut microbiomes, and that there's this bacteria that lives in our gastrointestinal tracts. And the hypothesis is there needs to be a whole lot more studies, is that us young people are not getting enough fiber from our foods that we are consuming now because of ultra processed foods. And so note, get more fiber. So I don't know, it's scary. It's scary to be in this age cohort. It's scary to hear your friends getting these diagnoses and then also see these epidemiological trends. So we'll see. Things that don't change is one, early screening, right? Keep screening, eat your fiber, try to eat as healthy as possible, as well as another theme is we need more research. What do you think, Abdul?
Yeah. So I think the whenever to your point, uh, whenever you see an increase in some disease like this, especially among young people, like sometimes when you see an increase in disease among older people, it's because of an unmasking effect, because of a decrease in another disease, right? So, the onset of prostate cancer in some respects is a function of people not dying of other things, which is like good. It's bad to have prostate cancer, but it's good that people are living long enough such that they're old enough to get prostate cancer later on, right? We still need to do something about the prostate cancer, but that's an unmasking effect. When you have an increase in a disease in young people, there's some new onset causal feature. And, obviously we're talking about the gut. And so a lot of this sort of points to what you eat. I do think, though, that the point about fiber, fiber is one of those things that we don't pay enough attention to. And it is easy to avoid in ultra processed foods because most of the time, like it's just not put there. And as I think about like the food choices, I'm increasingly thinking about like adding fiber both to my meals, but also probably even more importantly to my kids' meals, is something that we actively try and engage with. The other key point is, right, we know how to screen for colorectal cancer, and that is colonoscopies. And I'd be interesting to understand if the recommendations on colonoscopy will change in the near future, given the rise in early colorectal cancer in young folks. And so I would be looking over the next decade and thinking that these recommendations are, instead of starting at 45, may actually be starting a bit younger, given what we're seeing in young folks. So get your fiber, folks.
Yeah, but remember, those recommendations are tied to the US Preventative Task Force that is now been paused from RFK Jr., probably because of a redesign that he's going to stack it. So, yeah, we'll see. But I agree, Abdul. This is definitely a trend. This is not an error. There's something going on. How do we better protect the populations? Likely more screening. All right, Abdul, who'd you talk to this week?
A great conversation with Dr. Elaine Batchlor. She's the CEO of Martin Luther King Jr. Community Healthcare in South LA. Her work is entirely about providing healthcare to some of the most underserved people in the country, particularly communities of color. Their community, as everybody knows, has been hit hard by ICE raids. And so she's thinking through how do you make sure that folks get the healthcare that they need, regardless of their circumstances, in situations where that's just become a lot harder. And then, of course, make matters worse, add insult to injury, we're watching down the pike where this big ugly bill is going to be cutting Medicaid, particularly for folks who otherwise would have been able to bring that Medicaid reimbursement dollar to these healthcare centers. And so it's about to make the challenge that Dr. Batchelor is working through that much harder. So we talked about the impact of these impending Medicaid cuts, how they're going to try and stay open to serve the communities that they serve despite it, and how she's thinking about where healthcare needs to go moving forward. So it was a really good conversation, and I do hope that folks will stay tuned.
Absolutely. Enjoy your time in LA, Abdul.
Yeah, thank you. I'm enjoying your lovely weather, but Michigan summers are still better.
Or to go to that berry farm.
Yeah, no, I will tell you this. I had the single most delicious strawberry I've ever had in my life.
I
I picked it
bet.
right off the vine, and it was like warm because it was under the sun. And imagine having like a little packet of strawberry jam explode in your mouth. That's what it felt like. It was like truly, I mean, I laughed. It was one of those things where I was just like, just a sheer expression of just pure joy eating these strawberries. And I just couldn't stop. I ate so many of them. I probably like ended up eating a ton of dirt too, but like, maybe it's fiber, it's roughage. But man, yes, if you ever have the opportunity to go to a berry farm up north in Michigan, especially like in early July, do not miss that opportunity. Phenomenal.
All right. I'm putting it on my to-do list.
All right, friends. See y'all soon. Thanks,
All right.
Caitlin.
Bye.
All right, let's get going. Can you introduce yourself for the tape?
Hi, I'm Dr. Elaine Batchlor. I am the CEO of MLK Community Hospital and Healthcare System. And I believe we can do a better job of providing healthcare for our residents and keeping our population healthy.
I agree with that. All right, so tell us a little bit about MLK Community Health and a little bit about the community that you serve.
Sure. MLK Community Hospital and Healthcare is a health system that is located in South Los Angeles. We serve over 1 million people who live in the community of Watts, the city of Compton, and Linwood. It is a historically underserved community of color. The hospital system that I lead has its roots in the Watts Uprising of 1965, and it's really a system that serves a very low income community that is mostly brown and black people.
That is really critical, especially in a moment like this one where we're watching as this administration is targeting these communities in pretty direct ways, especially considering the way that they weaponized our military against people in LA. I want to ask you, just stepping back, what are the biggest challenges that you face running a healthcare system that cares for lower income communities of color in an urban environment?
So I think the biggest challenges that we face are the lack of resources and the lack of healthcare infrastructure. So this community evolved over time as one of the few communities in Los Angeles where African Americans could live, and was subject to redlining and to housing covenants. And over time, it became a community of concentrated poverty that lacked a lot of the same type of social infrastructure that you see in other parts of most cities. So really lacked education, housing, transportation, employment, and had an almost complete lack of access to healthcare. And that lack of healthcare infrastructure has persisted over time. Today, we have 1/10 the number of doctors in this community that your average community in California has. We're missing 1,500 physicians here, and it's really a desert of all kinds of healthcare.
One of the aspects of this is I'm a two-time health director, largely in urban communities, and one of the things that doesn't get talked about often is that it's not just the lack of healthcare access, as you talked about. It's the lack of the means of health in the first place, right? When you provide healthcare for communities who, by definition, lack access to healthier foods or breathe more polluted air or go to schools that don't spend as much time, energy, or money educating kids, all of these things are down to make people sicker in the first place. So when you're in a situation where you're caring for people's health in those communities, it's just harder by definition to do. And so it's not like you need the same amount of healthcare resources. In fact, you need more healthcare resources in communities like this.
Yes, that's absolutely true. All of the things that you just cited, the lack of safe places to exercise, the exposure to pollutants, the lack of transportation, all of those things are related to healthcare and healthcare status. And as a result, it's also a community where health indicators are much worse than in the rest of the county, where diabetes is epidemic, where behavioral health challenges and um, chronic illness are epidemic for those same reasons that you just cited, the lack of social infrastructure.
Yeah. And I really appreciate just the heroic work you all do every day to make health possible for folks in those communities. America Dissected is brought to you by Quince. I'm not into chasing trends, but I am all about stuff that fits right, feels good, and actually lasts. That's why I keep coming back to Quince. Their lightweight layers and high quality staples have become my everyday essentials. Quince has the kind of stuff you'll actually wear on repeat, like breathable flow knit polos, crisp cotton shirts, and comfortable lightweight pants that somehow work for both weekend hangs and dressed up dinners. The best part? Everything with Quince is half the cost of similar brands. By working directly with top artisans and cutting out the middleman, Quince gives you luxury pieces without the markups. And Quince only works with factories that use safe, ethical, and responsible manufacturing practices and premium fabrics and finishes. Look, there's nothing better than a good pair of loose linen pants in the steamy summer months, and I absolutely love my Quince linen drawstring pants. They keep me cool and look the part doing it. I can pair them with a V-neck t-shirt, a polo, or a button-down. Stick to the staples that last with elevated essentials from Quince. Go to quince.com/AD to get free shipping and 365-day returns. That's QUINCE, quince.com/AD to get free shipping and 365-day returns. Quince.com/AD. I want to now step into the space that I think a lot of our minds are in, which are around Medicaid cuts, because a large proportion of your community, if they're insured at all, are likely insured on Medicaid, or in California, as it's called, Medi-Cal. Um, as you started to hear about, Medicaid cuts and the work requirements that they're trying to impose on folks to get access to that, what was your reaction early on before this actually big ugly bill got passed?
Well, as soon as I started to hear about the possibility of Medicaid cuts, I became very concerned. We are already struggling with insufficient funding and insufficient resources to meet the health needs of our community, and cutting back on what we have now will just make matters worse. Our community is so low income. Medicaid is the predominant payer. Our patients and our residents are dependent on Medicaid, and we as a healthcare provider are dependent on Medicaid. And unfortunately, it already doesn't cover all of the costs of providing care. So hearing that it's going to be cut makes me even more concerned about our ability to continue to serve our community and about our community's access to healthcare.
What's that going to look like for people? Can you paint a picture about what that looks like for you? What are your worries as we head into this new regime of an era where Medicaid is getting cut for folks who otherwise would get care at your hospital?
Well, we're taking a step backwards. We're going back in time. We've seen what that looked like in the past, and what it looked like is even worse access to care. It looks like residents who will lose access to prevention, primary care, early detection of diseases, and disease management. People who will then forego getting health care until their conditions are much more serious, at which time they will then be forced to present to emergency departments and community hospitals, and will have more expensive and more advanced medical problems than if they had gotten care earlier in the course of a disease, or gotten the type of prevention that we know everyone needs. So I think that, what it's going to look like is less access for our community. It's going to look like providers struggling to stay open and continue to offer the services the community needs. And when some of these providers close, patients will then overflow into adjacent communities where they will also put a strain on their access to healthcare resources. And it also looks like providers absorbing uncompensated care, what we call uncompensated care, which is what happens when people are finally forced to go into an emergency department. We're required to take care of them. They're not able to pay. We have to absorb that cost. And that will make financially fragile providers even more shaky. Some of them will close services, some will have to close down. Providers in more affluent communities will pass those costs along to people who are privately insured, and healthcare for all of us will be more expensive. So I don't really see it being a positive for any of us.
Yeah, that last point, I think, is something that people don't always appreciate. Is that when you start imposing these work requirements on Medicaid, it's not like these people who are kicked off the Medicaid rolls don't still need healthcare. They're just going to get it in the most inefficient and expensive way, right? And it's inefficient in the sense that it's better to prevent the disease than to let the disease fester and care for it when it's emergent. And it's expensive because emergency rooms are just really, really expensive. And that cost that gets borne on to the rest of us. And so people don't really understand that, like, when we talk about the bill, right? Yes, that is that thing that got turned into law, but there's also a bill that comes due. Like, we're going to end up having to pay for it, all of us who may have private insurance, because either we're going to watch as our rates go up because of the renegotiation that has to happen for hospitals to try and push more of this uncompensated care onto us, or it's going to come due because hospitals that we previously could go to get healthcare, particularly in rural or urban communities, are going to shut down. As you think about how you make up for that uncompensated care, have you started to think about what your plan looks like in a world where you're going to end up having to try to eat more of this cost?
Well, yes, we are starting to think about it. And I just want to comment on one aspect of what you just said about people having to go to providers and hospitals in other communities. This community has actually been through that experience.
Hmm.
The original hospital that opened after the Watts uprising, which opened in 1972, closed in 2007. And when
Wow.
that hospital closed, the people who lived in South LA went to hospitals all over the city and the county. And so those hospitals will be impacted if services at this hospital are impacted. So we are going to do everything we can to keep this hospital open and continue to serve the people in this community. One of the things that we've already started to do is to work with our state and local healthcare leaders on on things that can start to fill the gap in federal funding. Unfortunately, a lot of states are not in a position to be able to fill the gaps that are going to be left by the bill, but we need to start talking to folks about that.
I I want to ask you, right, because there are a lot of unique communities that have been targeted by this administration, and none more so than undocumented folk. And I want to ask you, this is all coming at a time where ICE raids have become, just flagrant in terms of they said they were going after the quote unquote criminals, and then they wanted to make everybody quote unquote criminals. Now you're seeing babies get separated from moms and moms get separated from babies. And so this is a community that has been targeted in a really profound way. And even folks who have some legal status still are finding themselves caught in the system. Folks literally coming out of their court appointments and getting picked up by ICE. How will this and how has this moment affected the kind of care that you can give to undocumented people? And then what are the long-term implications of the inability to provide quality care for this community for everyone?
Well, I think that, two things come to mind immediately. First is just the fear that people have to even go to the doctor or go to a hospital when they're sick and they need care. So we've already seen a ripple effect of people being fearful to go to see a doctor for their regular appointments and regular medical care. So I'm concerned about that because again, if they don't get that primary care, prevention, disease management, um, they are going to get sicker, and we're going to end up paying more to provide, higher tech rescue care for patients. Um, and then the second issue that I'm concerned about is the decrease in resources that we will have as a provider that will make it harder for us to take care of all of our patients as a result of the federal Medicaid cuts. And, again, it will have the same effect of forcing people to wait until they are sicker to get care. It will cost us all more, and it'll put more strain on an already shaky healthcare system.
Yeah. And that's the thing that folks don't understand is that, like, at the end of the day, our failure to care for any of us ends up making it harder to care for all of us. As much as we like to think of ourselves as individuals disconnected from others, we all live in this place, and when we don't consider what's best for any of us, we fail to consider what's best for all of us, and frankly, the life that we save might be our own. I want to ask you, right, because this comes on the back of a moment in 2024 where the expansion of Medi-Cal to include income eligible adults, regardless of immigration status, was really a big win. And it seems like a lot of that is getting rolled back now. Can you speak to like the interim difference of what it was like to have that expansion and then what it's going to look like now?
Uh, well, I think that what the expansion brought was the ability of everyone to at least have a primary care provider and to have access to medical care when they need it. And I think that the difference is going to be huge. People are going to avoid going to doctors. They're not going to be able to afford to go to doctors until they are quite sick. And we're going to see access worsen. We're going to see health status get worse. And we're going to see providers weakened by having to absorb more uncompensated care. So I think we're going back to the days when hospitals had, very significant uncompensated care depending on where they're located. And if you're a hospital like ours that's located in a low income community where there aren't a lot of privately insured people, we're talking about a significant increase in uncompensated care at a time when we're already struggling to keep our doors open. So I think we're looking at, sort of the wholesale weakening of our healthcare safety net.
Mm, that's a really profound point, and I think that's one that all of us need to be thinking about. I want to ask: are there viable workarounds in the moment, like things that we could do to soften the blow?
I think there are things that we can do to soften the blow. And I think one of them is something that we have already been doing for quite a while, but I think we'll have to, sort of ramp it up. And that is providing our patients and people who live in our community with assistance enrolling in programs that they're eligible for. So one of the things that we do routinely is when patients come to our hospital or present at one of our outpatient practice sites and they haven't already signed up for Medi-Cal, we actually have a vendor that we work with that reaches out to them and helps them get the paperwork done and get enrolled. And I think with the increase in eligibility redeterminations and with the new work requirements and the paperwork that's going to come with both of those, we are really going to need to, kind of wrap our arms around our community and help them get that paperwork done. So that is one of the things that we can do to, I think, mitigate some of the damage. I worry, though, that patients may be fearful of sending paperwork in because of the immigration issues that you raised earlier. Even people who aren't undocumented may be worried about that. So I think that's going to be something that's going to make it harder for us. But that is one of the things that we can do. One of the other things that we've done as a health system is we have proactively assessed the financial status of our patients. And when we have evidence that they are not able to afford to pay for healthcare, we write the healthcare off. We don't even send them a bill. So we're not sending them into medical debt. And I think that is something else that can be very helpful. It does, incur a cost for the health system, but if people can't afford healthcare, sending them into medical debt doesn't really do anything for us. It doesn't improve our financial status to send someone into collections who can't pay. It just hurts that person. And so I think that's another thing that we can do to soften the blow.
I want to ask because, a lot of this is going to need public policy to solve. And I'm wondering if you're seeing anything, whether it's at the local level or the state level, around trying to mitigate the consequences that the federal policy are going to create that could be really helpful, or where you'd like to see that kind of leadership happen if it's not happening.
Sure. I do think that we are going to need stronger leadership, both at the local level and at the state level, to help providers and communities cope with the federal cuts. I don't want to suggest that states and local governments have all the resources they would need to make up for these cuts, because these cuts are huge and they aren't going to be able to fill in all those gaps. But I do think we have to work in partnership to really try very hard to preserve access and preserve the providers that are providing the care in these communities. And I can give you some examples. So this past Tuesday, we worked with our local county supervisor on a small increase in funding for our hospital that will be critical in getting us through our current fiscal year. Without this additional funding, we would be cash flow negative by the end of the calendar year. And we worked with our local county supervisor. We had our supporters go down to the County Hall of Administration, and we were successful in getting this additional funding. We need to do the same kind of work at the state level. And we need to make sure that we are also not, giving up on at the federal level. Just because they passed a bill doesn't mean that we can't have, other bills that might reverse some of the things that have already been done or soften them. We know that there's a senator who's already introduced legislation to attempt to change some of the cuts that have already been made. So I think we have to continue to work with our political leaders at a local level, state and federal level.
Yeah, I really appreciate that point, because I think, you know, eh, as much as the federal government is weaponizing against all kinds of people who have been pushed to the edge of life in America, I think state and local governments are in a position to try and do their best. Now, of course, so much of the funding that they require comes from the federal government, but smart policy, especially working with community leaders like you and providers, I think can be very valuable. One of the things we talk a lot about on our podcast is just about public trust in health and healthcare. And I want to ask you, right, because once you lose your healthcare coverage, it changes the way that you engage with health. You're now disenfranchised in a way where you're sort of stuck in the alternative to evidence-driven medicine. What impact do you think this is going to have on patients' behaviors, on the broad public support for the kind of care that you provide in the clinic and hospital?
Sure. Well, I think you're correct about that, and I hope that it won't further erode the trust that people have in healthcare organizations and in their providers, because that trust is critical to keeping our population healthy. But being put in a position where you don't have access or you don't have coverage to create that ongoing relationship with a provider is going to make it harder to build that trust. So I think it's going to make our job as providers harder.
Yeah. That's the hard part, right? Is that we're actively pushing a lot of these folks into the arms of mis and disinformers, in large part because they don't have access to evidence-based treatment in the first place. And I worry about what the impact is going to be on trust. I talk about this all the time, but in an era where we were offering free COVID vaccines, meaning a medication for a disease you did not yet have, it was crazy for a lot of people when they couldn't afford basic things like insulin, right? Medication for a disease you have that you can't afford. And so if you cannot give people the treatments for the diseases they know they have, it becomes very, very difficult for us to earn the kind of trust in moments of crisis like in COVID. And I think we have to recognize that these two things are connected. As you look into the future right now, Dr. Batchlor, you guys are in a situation where you're caring for folks who fundamentally need care, who are at risk of losing it. Is there anything that gives you hope that you can leave us with as we think about next steps and what we can do to protect the kind of folks you've been providing care for a long time?
Well, the experience that I described earlier, where we went down to the County Hall of Administration and advocated for additional funding for our healthcare system, actually did give me a lot of hope, because there was a tremendous outpouring of support by our patients, our staff, our community partners. And it was a perfect example of the power of grassroots advocacy, and, of having a community come together. And that is what gives me hope, is that people get engaged, people get activated when they realize what's at risk, and they come out and they demand better, they ask for better, and they ask for, the support that our communities need. So that is something that gives me tremendous hope.
Well, we really appreciate that. And it's a reminder that all of us are engaged in this work together. And especially in a moment like this, where you are watching the cruelty unfold from some levels of leadership at the government, it reminds us that those of us who believe in hope and empathy have to band together to demand better and provide better for folks who absolutely need it. Our guest today is Dr. Elaine Batchlor. She is the CEO of MLK Community Healthcare Hospital and Health System, providing care to 1.3 million residents of a medically underserved community in South Los Angeles. Dr. Batchlor, thank you so much for your time today.
Thank you. I enjoyed it.
That's it for today. You can find more content on our website, incisionmedia.com. Check out our shop at store.americadissected.com for our new America Dissected merch, including logo shirts, hoodies, and mugs. And don't miss out on our Make America Scientific Again dadcasts. If you have guest recommendations for the show, send us an email at info@incisionmedia.com. You can follow or subscribe to America Dissected on your favorite podcast platform and on YouTube at America Dissected. You can follow me on Instagram, TikTok, and Twitter at Abdul that's no dash. Make sure to subscribe to Katelyn's incredible newsletter, Your Local Epidemiologist, which breaks down the latest scientific evidence for over 300,000 followers. Search for Your Local Epidemiologist on Substack. Links to all our sponsors are available in the show notes. Please do check them out, show them some love, and make the show possible every week. And on your way out, don't forget to leave us a 5-star review. And if you're watching on YouTube, drop us a like or comment. Word of mouth still goes a long way. So if you know someone who might like to keep up with everything that's happening in the world of health, let them know about us. America Dissected is a product of Incision Media. Our co-host is Dr. Katelyn Jetelina. Our producer is Andy Gardner-Bernstein. Video and audio editing by Nadine Malkonian. Our theme song is by Taka Suzawa and Alex Sugiera. Sales and marketing by Joel Fowler and Nick Freeman at Big Little Media. Our executive producers are Tara Knight and me, Dr. Abdul your host. Thanks for listening.
This show is for general information and entertainment purposes only. It's not intended to provide specific healthcare or medical advice and should not be construed as providing healthcare or medical advice. Please consult your own physician with any questions related to your own health.